Ladies and gentlemen of the House, I'll be brief. Last year we passed House File 524, which was the medical cannabis program. The comments that I'm going to talk about is how the programs is sustainable. And so the sustainability of the program relies on urgent action during this session. Without change, we will essentially have a program with conditions that cannot be treated. We have a duty to patients with approved conditions to provide them with medicines that can treat their conditions on day one, which is December 1st. Without passing something new, we are failing in the legislature. Why do we have a mismatch in the system? We have conditions such as cancer, pain, HIV that need THC like states with robust medical programs. But we also have a cap similar to states that only treat epilepsy. This means we have approved conditions that we cannot realistically treat, which was not the original intention of care. Studies have shown a wide range of THC needed is between 5 to 300 milligrams a day. So here's an example of the THC cap that we have. So when you take a pill like Advil, we know how many pills we need and how many active milligrams that is. This may be 1 or 3 pills. A person taking medical cannabis is the same. They know how many active milligrams of THC they need, which could be a range from 5 to 300 milligrams a day. The current cap does not change the dose someone needs. It just keeps them from economically and realistically taking their dose. The 3% cap doesn't change the numbers of milligrams a patient needs. So in other words, our current cap does not change what a patient would need for treatment. Example, if someone needs 150 milligram THC, they will need this amount for pain relief with or without a cap. With the cap, however, we are asking that a patient to take 15 pills as opposed to 1 to 2, which adds much more cost to the patient. This is absurd, and this is how the program currently stands. Asking a patient to take 15 pills a day to reach their effective dose for pain control is not humane or economical way to provide treatment to patients. This cost would be about $45 a day for that patient. The most complete body of research for efficacy of THC is in pain relief. It is unfortunate that those patients also need higher doses of THC, and under the current system would likely not be satisfied with care. So pain definition. The definition of pain needs to be changed in order to serve a wider section of Iowans suffering under the umbrella of pain conditions. Current definition is clunky and is unclear to doctors who do not know if they have met all the criteria. Refine the language to say to other states is severe and chronic pain. Other points, opioid. We've all had discussions about the opioid epidemic that we currently face here in Iowa. States with medical cannabis programs have decreased opioid and prescription use, equaling $400 million in Medicaid savings in 2014. The Cannabidiol Board, the board has not made any recommendations around those issues. Change in the THC is our responsibility, not theirs. We would make that. The board does not have enough background in this specific area to be able to make recommendations in a timely fashion. One way to combat would be to put condition decisions back into the hands of doctors, letting them decide if their patient's condition is appropriate for medical cannabis. So in conclusion, legislature needs to take action to make sure the conditions they have approved are able to be treated in a realistic and economic way for patients of Iowa. This should be done via removal of the THC cap, addition of conditions, and clear definition of pain. And I know that currently Senate File 2372 addresses many of these issues and concerns. So I know we have a few weeks left before we're done. I would love to work with others in here to get this moving forward so that we can help Iowans that are struggling with significant illnesses and pain. Thank you, Mr. Speaker.